Mhm.
So, hi everyone. Today I will be discussing an article on the topic differences in morphology of temporomandibular joint ankylosis of trauma and infective origin. So, this was an article which was published in the International Journal of Oral and Maxillofacial Surgery in the year 2023 by Mubashir et al. So, coming to the introduction, what is TMJ ankylosis? So, this TMJ ankylosis can arise from the trauma or infection. The morphology can differ significantly depending on etiology. So this study aims to access the morphological differences using the CBCT. So the objectives was to identify the morphological variations in TMJ ankylosis of traumatic versus infective origin. So CBCT was used for imaging to classify and compare the differences and to correlate the findings with clinical management and implications. So coming to the study's design, it was an observational retrospective comparative study that included 40 patients of traumatic joints, 28 patients, and infective joints, 15 patients, and CBCT was used. Then coming to the inclusion criteria, a confirmed etiology, either traumatic or infective, available complete radiographic and clinical data, and scans between 2013 and 2021 at PGIMER, Chandigarh were used. So exclusion criteria, so recurrent TMJ ankylosis cases and unknown cause of ankylosis and incomplete imaging of or clinical records. Coming to the CBCT evaluation parameters, so these six parameters you should be knowing for your exams as well. So the residual condyle or the glenoid fossa, I will be discussing each one of them in detail first. Before comparing them in the study, I will be discussing each one in detail. So the residual condyle or glenoid fossa, juxta-articular bone growth, fusion line, sclerosis and erosion, air cell obliteration, and ramus thickening. So first of all, coming to the residual condyle, so it is present in 96.4% trauma joints and it was absent in 100% infection joints. So it was a statistical significance that p less than 0.001. So the residual condyle, so what is the residual condyle? So residual condyle was defined as the part of condyle that was not fused with the skull base. So the here in this image we can see the white arrow, the residual condyle lying medially. So the red arrow, which is the juxta-articular bone formation on the lateral side of the joint, and the star demarcates the fusion line. So currently I'm discussing only the residual condyle, not the juxta-articular bone formation and the fusion line. So once again, I will be speaking that the residual condyle was defined as the part of the condyle that was not fused with the skull base. So it can be classified as type 1, the medially present residual condyle, more than three-fourths of the condylar head. Then coming to the type 2, the medially present residual condyle is half to three-fourths of the condylar head. Then type 3, the medially present residual condyle is one-fourth to half of the condylar head. Then type 4, the medially present residual condyle is less than 1 by 4 of the condylar head. So now coming to the residual glenoid fossa. So the residual condyle glenoid fossa was present in 75% of the trauma cases and absent in all of infection cases. So it was also a statistical significance thing. So p less than 0.001. Then what is the residual glenoid fossa? So similarly, as the residual condyle was there, we can say that the residual glenoid fossa was defined as the part of the glenoid fossa not involved in ankylosis. So here we can see that there is erosion of both the glenoid and fossa and the condyle, sclerosis of the spongiosa of the glenoid fossa, then the glenoid fossa apposition, that is an increase in thickness of the roof of the glenoid fossa due to the bone deposition. Here we can appreciate in this image that the thickness has been increased of the roof of the glenoid fossa due to the bone deposition. Then coming to the classification of residual glenoid fossa, the type 1, the residual glenoid fossa is more than 3 by 4 of the glenoid fossa. Then The residual glenoid fossa is half to 3 by 4 of the glenoid fossa. Then type 3, residual glenoid fossa is 1 by 4 to 1 by 2 of the glenoid fossa. Then type 4, the residual glenoid fossa is less than 1 by 4 of the glenoid fossa. Coming to the juxta-articular bone formation, so it was present in 96.4% of the trauma cases and absent in all infection cases. So coming to what is the juxta-articular bone formation? So the lateral juxta-articular bone formation was defined as the ankylosing bone mass extending laterally from the ramus of the ramus and glenoid fossa or zygomatic arch of the TMJ. So coming to the red arrow, we can see the juxta-articular bone formation on the lateral side of the joint. So, coming to the fusion line and extension, so the trauma joints had 85.7% fusion line seen, extending mostly laterally, and infection joints had the fusion line mostly limited to the joint, and then they had the significant difference in fusion extension pattern. So, in this image, we can see the fusion line was defined as the hypodense plane present within the ankylotic mass, separating the ankylotic mass into a glenoid part and the ramal part. So the star demarcates the fusion line. So erosion. So this is the next parameter. So erosions of the ankylosed condyle were present in 85.7% of the ankylosed joints in the trauma group and 76.9% ankylosed joints in the infections group. So erosion was defined as the concavities in the cortical outline of the mandibular condylar surface with indistinct cortical outline. So this image shows the glenoid fossa apposition with the erosion of both the condyle and glenoid fossa and sclerosis of the spongiosa of the glenoid fossa. So three infective ankylosis joints had a relatively maintained cortical outline on the posterior one-third of the condyle. So this intact cortical outline of the condyle can be seen in this image. So erosions were found on the anterior portions of the condyle and articular tubercle and at the level of the sigmoid notch. The cortical outline of the residual condyle and residual glenoid fossa was maintained in 96.3% of the ankylosed joints in the trauma group. Now coming to the ramus thickening, so 82.1% in trauma versus 53.3% infection. It suggests greater bone adaptation post-trauma. So it was defined as an increase in bicortical width of the ramus of the mandible. So now coming to the sclerosis of the condyle. So it was present 100% in trauma group and 60% infection group. Different patterns of sclerosis distribution was seen. So it can be defined as a thickening of the cortical outline of the joint surface with loss of marrow hyperdensity. So we will be classifying it into type 1, involving the articular surface of the ankylosed condyle only, then involving the lateral part of the ankylosed condyle, so involving the ankylosed condylar head, and extending beyond the condylar neck up to the mandibular foramen. Then type 5, extending up to the ankylosed condylar neck. Now coming to the similarly, now we are coming to the sclerosis of the glenoid fossa. It was present 100% trauma versus 46.7% infection. Another key differentiating parameter. So, in the infective ankylosis, sclerosis may be explained as being due to reactive bone formation in response to chronic infection. So, infection of the joint affects the articular surfaces of the intervening disc and the adjoining structures, thereby damaging them. In response to these changes, the bony structures develop sclerosis. So, glenoid fossa air cells are accessory mastoid air cells existing in the articular eminence and zygomatic process of the temporal bone. So, the obliteration of the mastoid and the glenoid fossa air cells can be due to either to direct trauma or to chronic infection arising from the joint that spreads to the mastoid bone and adjoining temporal bone, or vice versa. In the current study, obliteration of the mastoid and accessory cells was found predominantly in the infective ankylosis. An important finding in the temporal bone thickening was also seen in one patient with infective temporomandibular joint ankylosis. Then the air cell obliteration, the mastoid obliteration, more in infection, 23.1% versus trauma. Glenoid obliteration, slightly more in infection, and suggests infective origin involving adjacent structures. Coming to the air cell obliteration, the mastoid and glenoid fossa air cell obliteration was defined as the hyperdensity or opacity within the air cells, leading to partial or complete loss of the air cells. In these both the images, we can see the mastoid air cell obliteration, and in the second image, we can see the glenoid fossa air cell pneumatization and obliteration of the ankylosed side. So coming to the statistical analysis, descriptive and inferential statistics were performed using SPSS software, and Fisher Exact, Freeman, Halton were used for the comparisons, and significance was p less than 0.05, and intra reliability used Cohen's kappa. So the results were as follows: the trauma group 25 patients, mean age 19.2 years. Infective group, 15 patients, mean age 14.5 years. No statistical differences in age, gender, and ankylosis duration. So the mouth opening, the mean preoperative mouth opening was also similar in the two groups. The trauma group 7.2 and infection group 6.3 mm. Then these are the demographic characteristics as discussed earlier. These are the morphological parameters. So we have discussed these before. You can check the number of patients in each group in this chart. Then I have written this in this table in an easier form. So the residual condyle and the glenoid fossa in the traumatic one was 96% and 0% in infective group. Glenoid fossa 75% in traumatic group and 0% infective group. Just articular bone growth 96% in traumatic group and 0% infective group. So the cortical outline of the ankylosed part of the condyle was absent in 24 out of 28 ankylosed joints in the trauma group, as compared to 13 out of 15 ankylosed joints in the infection group. Complete fusion between the glenoid part and the ramal part was found in 4 traumatic ankylosis joints, and whereas it was seen in 2 infective ankylosis joints. So the discussion part, the prevalence of TMJ ankylosis of infective etiology is quite low, and only 15 cases of infectious etiology reported over a 9-year period could be found in this study. Therefore, the two groups could not be matched. The main differences in the morphology of TMJ ankylosis were that lateral juxta-articular bone formation, residual condyle, residual glenoid fossa, juxta-articular fusion, ramus thickening, and sclerosis of the ankylosed condyle and glenoid fossa were predominantly found in traumatic ankylosis. Intra-articular fusion, a relatively maintained architecture, and mastoid air cell obliteration were predominantly seen in the infective ankylosis. Then, juxta-articular bone formation was exclusively found in the traumatic TMJ ankylosis. The reason for this could be due to sagittal fracture of the condylar head with lateral displacement of the condylar segment. Then, if the displaced lateral condylar segment becomes stuck with the outer edge of the glenoid fossa or the root of zygoma, ankylosis may result. Coming to the clinical implications, the trauma ones need to be preserve residual condyle when possible. Infection ones may require full reconstruction, and the CBCT is a helpful in pre-operative planning and diagnosis. So the limitations of this study was there was a small sample size infection group, retrospective design, and the single center study. The conclusion was that the CBCT effectively differentiates the traumatic and infective TMJ ankylosis. Then I have added some of the articles for comparison point of view. So the Lemierre syndrome leading to ankylosis of the temporomandibular joint. So the abstract was as follows: that the Lemierre syndrome, also known as the Lemierre's disease, is a rare condition that was first described by Andre Lemierre in 1936. So they presented a case of a 3-year-old boy who presented with ankylosis of the right TMJ secondary to mastoid infection as part of the Lemierre syndrome. So his ankylosis resulting in a restricted mouth opening, which had a considerable impact on his speech and ability to eat. So the surgical treatment comprising right coronoidectomy, gap arthroplasty of the TMJ, and interpositional fat grafting enabled him to move his jaw, and function has returned. So that this case report highlighted the consequences of Lemierre syndrome, and the need for clinicians to be aware of its features and the impact it may have on the patients. So this is the second article, the temporomandibular joint ankylosis following mastocytitis. This is a case report. So they had a case of TMJ ankylosis following otitis media and mastocytitis. So the its treatment and treatment was described in this article. You can refer to this as well. Then this was another article, supralateral dislocation of the mandibular condyle, report of two cases and review of the literature. So the summary I have written here below. The superolateral dislocation of the condyle due to sagittal fracture of the condyle has a cause of ankylosis. Trauma to the joint may cause damage to the articular and periarticular tissues, intra-articular hematoma formation, and extension of hemorrhage to the extra-articular tissues, thereby bypassing any impediment posed by the articular disc. Ossification of the hematoma at extra-articular sites on the lateral side together with the fusion of the displaced lateral condylar segment with the skull base may present as a juxta-articular growth. Then coming to the bony ankylosis of the temporomandibular joint, computer tomographic study. So the summary was that it reported sclerosis of the skull base in ankylosis cases resulting either from trauma or from non-specific causes. You can read this abstract below. Then so there was an Indian study of the TMJ ankylosis, which I have added at the last. So the 75 condylectomy and coronarectomy specimens of the TMJ ankylosis in 61 patients were studied. 14 patients had bilateral ankylosis, 6 of whom had fibrous ankylosis on one side. There were two types of ankylosis, intra-articular and juxta-articular. Intra-articular ankylosis was seen only in re-ankylosis or in post-infective cases. 66 cases were post-traumatic juxta-articular ankylosis. A rudimentary temporomandibular joint with an atrophic condylar articulate surface was found in all juxta-articular ankylosis. The size of new bone in the specimens varied from 0.5 to 3 centimeter. Fusion of the extra-articular bone mass with tympanic plate was also observed. Contracture of temporalis muscle was noted in all the cases, which made excision of the coronoid processes mandatory in all the arthroplasties. Arthroplasty early in the childhood did not hamper growth. Instead, facial remodeling was enhanced. Thank you.